In this video, I'm going to share the 5 treatment steps that you can use to treat any type of groin injury in runners. Then I'll explain how you can tweak them depending on what structure you've actually injured. We'll run through the most typical types of groin injuries runners get and the symptoms that distinguish them. But I will also explain what you can do and how you can still effectively recover even if you can't get a super specific diagnosis for your groin pain. For those of you who don't know me, my name is Maryke. I'm one of the physiotherapists from sportsinjuryphysio.com, where you can get online physiotherapy assessment as well as treatment for any type of sports injury, all done by a video call. If you want to know more about our online service, have a look at the description of this video. I'll put a link to the website there. Step 1 is figuring out what's actually causing your groin pain. The groin is an extremely busy area. You've got your hip joint in there, you have your pubic bones coming together, forming your pubic symphysis at the front, you have your hip flexor tendons coming across, your abdominal tendons from the top, your adductor tendons, you've got lots of ligaments, and then the bones themselves that can cause pain. So the first step to getting your treatment optimized is 1, figuring out what structure you actually injured, but 2, figuring out what caused that injury in you. Because every person usually has a slightly different way of how they got to the injury, and you need to figure out what happened so that you don't make those same mistakes or you don't land up in the same position in the future. Now, I'm immediately forced to contradict myself. The 2 points I've just mentioned is what would happen in an ideal scenario. But because the groin is such a busy area, it's not always possible to get a super clear diagnosis that the doctor or the physio can say that is exactly what's causing your pain. It's quite common for scans to come back not showing much. The tests that the doctor or the physio does on you doesn't really marry up with your symptoms or what they're seeing in scan results. And this is not because the doctor is incompetent or the physio doesn't know what they're doing. It's really common in groin injuries, and it's because not all injuries can show up on scans clearly. If this happens to you, don't worry, you can still recover fully by following the steps I'm going to discuss in a minute, and I'll explain what you do if you don't have a clear diagnosis. The important thing is to rule out any serious causes for that groin pain. So you want to rule out things like a bone stress injury or cancer, for instance, or referred pain from other organs. And these things can all be seen clearly on scans or through blood tests. So if the test comes negative for those things, then you can rest assured that you don't have that and that yours is a typical runner's groin injury that just can't be seen on a scan. Before we get to step 2, let's just look at the 7 most common groin injuries that runners get. We'll cover adductor tendon injuries, hip flexor tendon injuries, abdominal muscle tendon injuries, osteitis pubis, hip impingement, hip joint injuries or hip joint pain. I'm putting a lot of hip joint injuries together in that one because their symptoms are so similar, and then also bone stress injuries. Now, you can also get referred pain from your lower back, as well as your organs, as well as some nerve injuries that causes groin pain there. But your physio doctor will be asking questions in your interview to understand how likely it is that the pain is coming from there. And the physical tests they make you do will also help them understand whether it's actually referred pain from somewhere else. So let's look at the typical groin injuries, and don't worry too much about referred pain from other places. Your doctor or physio will actually be testing for that. Adductor tendon injuries. We're talking about adductor tendon tears or tendinopathy, tendonitis, is the most common type of groin injury that runners get. So if you think of your pelvic bones coming together at the front and your pubic symphysis in that area, then your adductor muscles is a group of muscles running on the inside of your thigh. And the muscle bellies lie in this area, and there are quite a few different ones of them, and they attach at the bottom at different spots along the inside, even to below the knee. At the top, the tendons all come and attach at some point around the pubic bone. And depending on where or which tendon you've injured, you can feel that the pain more to the side front of the groin or even right under into that area. And this is where the main pain is, but it can make the adductor muscles feel quite tight and uncomfortable all the way down there as well. What do the adductors do? Well, when you're on one leg supported, they work in tandem with your hip abductor muscles to keep your legs stable. And depending on what movement you do, some of them help to flex the hip, some of them help to extend the hip, but they're very important with the control. And they also work together with your opposite stomach muscles to transfer weight through your legs as you run, as you walk, any movement that we do. Runners typically get adductor tendonitis or tendinopathy. And we're talking about runners who run in straight lines, trail runners, doesn't matter what distance, track and field runners. It's the guys who does sport that you have where you have quick changes of direction, like your football, soccer, any of those running sports, even things like ice hockey, that tend to be more prone to adductor tendon tears. However, it's not uncommon to get an adductor tendon tear in a runner, and it's especially if you've had groin pain for quite a while and it's just been carrying on, so you've had a tendinopathy for a long time, the tendon loses some of its strength, and then it's more prone to sustaining a tear when you have a sudden step or you're just doing a run and the impact is too much for it. So tears are not uncommon in groin injuries, but it is more common to get a tendinopathy or tendonitis. The difference between the two lies in how it starts. That's the biggest clue in how you can tell which one you have, if you're not doing a scan, obviously. With a tendinopathy or tendonitis, the pain usually starts gradually over time. So you'll notice during a session that it started to become quite uncomfortable in my groin, or towards the end of a run. Or usually it's several hours after a run that you think, oof, my groin's not happy today. Or the next morning that you wake up with that. And then it intensifies over several sessions. Often at the start, you can kind of run it off, that it loosens up and you think, oh, that feels better. But then it comes back later on. With a tendon tear, the pain or the symptoms, you have a sudden incidence when it happens. So you'll be running along and then you'll feel a sudden sharp pain or quite an intense moment or a jolt or something, and then the pain starts. If that happens, then it may be a tendon tear. And it is common to, like I said, have that history of a tendonitis where the pain started gradually and everything, and then suddenly you had a sharper event, which might mean you have a tear on top of a tendinopathy. And with tears, it's usually there's no warming up effect. When you start running, it just gets more and more uncomfortable. You can't run it off. So why do runners get adductor tendon injuries? Well, at the moment, there isn't any specific research on runners to say what the risk factors are, but there are some studies available for ice hockey as well as football and soccer. And those studies are showing that it's likely one of the causes might be when your adductors aren't as strong and in balance with your abductor muscles, which the adductors move the leg in, the abductors move the leg out. And remember, when you're on one leg, they have to keep you stable, that your hip doesn't drop and that your leg is in good control. So if the outside muscles are much stronger than the inside muscles, then the inside muscles are prone to injury. So that is one of the likely causes that could be part of it. But in our experience with tendon injuries, it's often just a case that the volume of exercise became too much or there wasn't enough recovery. And then the thing that gets injured in the body first is the one that doesn't have the best endurance or the best strength. So yes, it is that it wasn't as strong, but it's also the training load was likely too high or there wasn't enough recovery or something like that in there. Next up, we've got hip flexor tendinopathy or tendonitis. You've got quite a few muscles helping with hip flexion as well, which is bending the hip up, including your quad muscles, your sartorius. But the ones that we're interested in today with the hip flexor tendinopathy is the iliopsoas muscle, because that's the most common one, the lower tendons that's involved in tendinopathy. It's not common, actually quite uncommon, to get a tear in those tendons, but again, it's possible. But it's most likely that it's a tendonitis or tendinopathy if they're causing your trouble. Now, the iliopsoas itself is actually made up of two muscles, and they attach in interesting places. You've got the psoas muscle that actually attaches on the front or the inner part of your lower back bones, the vertebrae, and ram down. And then you've got your iliacus muscle that attaches on the inside of your pubic, your pelvic bone, and then come down. And their tendons come together and they attach on the kind of the inner front border of your femur. So if we think of where you feel this pain, the adductor pain is around this area, and your hip flexor pain is usually just a little bit more to the front, more in this area that you feel it. But it can refer down. If it's angry enough, it can annoy the adductor muscles as well. But you can also get discomfort up here, because remember, those muscles attach right into this area at the back there. You have your iliacus, and your iliopsoas comes up even higher to attach to this level on the front of the vertebrae. Because the psoas attaches to the front of your lower back bones, it works in more ways than just flexing the hip up. It actually helps stabilize your spine when you're sitting upright, like I'm doing at the moment without back support. And if you have an injury there, that can become really uncomfortable, and even cause lower back pain or pain at the front of the hip. But then also a common symptom that often occur when somebody has a hip flexor tendon that's not happy with life is that you develop a clicking in the front of your hip. And it can be quite uncomfortable, that it's like something flicking over a bone or something in that area. And that's exactly what's happening. So if you think of the tendons of the iliopsoas muscles, when the tendons are irritated, because they're attached to the muscles, it naturally causes the body then to tense the muscles. And they're pulling the tendons tight then. And instead of sliding over the bones like they normally do without much pressure there, they now kind of get a little bit stuck because they're being pulled too tight. And then they suddenly move over, and that's that click that you get. Sometimes the click is painful, sometimes it's not. It just depends on how annoyed the tendon is. But that usually improves as you start doing some exercises and things to help the tendons as well. Now, often the first exercise people want to jump in with when they hear this is hip flexor stretches, because you're thinking, well, I'll loosen it off. But that can actually make things worse and more painful if that tendon is very uncomfortable. I find some very light eccentrics where you just use the muscle in a way that it's got to lengthen under weight of your leg or something like that, depending on how sensitive yours is. There's different versions, is a much better way to get that muscle to just relax and calm down. But yes, that clicking usually disappears as soon as the tendon is happier as well. So what causes this to happen? Well, again, there's not much research into this, but because of how it attaches to the lower back and how it works with the leg to move the leg, lumbopelvic stability is very important for hip flexor injuries. Let me explain what that is. So if you picture your pelvis here again, let me just do that, then you can see where the top of my pelvis is. So that's the top of my pelvis, and I've got my lower back in this area. Now, if you can picture part of the iliopsoas attaching to my pelvis, can you see that if I keep this still and I lift my leg up, then it's going to have a certain way that it moves. But if, as I lift it up, I also let my pelvis come forward, then it's going to change how that muscle works. And it's going to change what happens in my lower back as well. So lumbopelvic stability just means that it's your ability to keep your pelvis stable while your leg moves, that it doesn't go forwards or backwards excessively, neither does it drop up and down as you lift that leg up excessively. So it's just about, can I keep this part stable, not dead still, just a little bit of movement while moving my legs as I run. And the thinking is that if this control isn't quite there, then it can overwork that hip flexor muscle. So this is also why part of the treatment for a groin pain that's caused by the hip flexor tendons should include core stability, but specifically lumbopelvic stability exercises where you focus on really controlling your pelvis while moving your legs. When we talk about abdominal tendinopathy, we mostly mean rectus abdominis tendinopathy. Your rectus abdominis muscles are your six-pack muscles, the one you see at the front of your stomach that runs down and it attaches to the front or the top edge of your pubic bone. So the pain you feel when you have your abdominal tendinopathy, if you can feel your pubic bone and you just move your fingers up to the edge, then it's along this top edge area, and the area that could be affected changes from person to person because we all have different shaped bones and different muscle attachments. But it's the muscles that come right down, straight down, and attaches into this area. And the main pain is felt in this area, but it can also refer over the front of your pubic bone, as well as down the inside of the leg, or even the opposite side inside of the leg. And these muscles work in tandem with your adductor muscles to help keep your pelvis stable as you run, that you don't get excessive movement in those areas. And it helps to transfer the forces created by taking your weight on your leg across your body. Abdominal tendinopathy typically develops in people who does a lot of strength training. So a lot of sit-ups, because it's an overuse injury of those muscles. But in runners, it's not that common to have abdominal tendinopathy without other injuries accompanying it. The exceptions where I've seen it that it's just abdominal tendinopathy is in women after they've given birth and perhaps they didn't regain full core control and stability in that area before they went back to running, or in very long distance runners where the amount of running and lack of recovery and things perhaps contribute to overuse of those muscles. But more commonly, they present with other injuries like your adductor tendon injuries and osteitis pubis, which I'll talk about in a minute. Now, there's even less research into abdominal tendinopathy in runners than the previous ones. But if we think of how those muscles work and what they do and what other muscles they work together with, then it's very likely that the strength of your adductor muscles on the inside of the thigh will affect how much load your abdominal muscles take, especially in very long distance runners. And then also lumbopelvic stability. So how your pelvis moves on top of your legs when you move, or how stable it stays when you move your legs, will likely also affect it. And therefore the strength in those muscles could be an issue. So whenever we see a patient with abdominal tendinopathy, it's not just about regaining the strength in those tendons, but it's about working on that core stability and making sure the adductor muscles and all the other muscles around the hips are also strong. Osteitis pubis is an overuse injury that is commonly seen mostly in runners that does really high volumes of quite intense training. And it's not just one injury. It consists of loads of different injuries, but it affects your pubic symphysis area. So right there where the pubic bones come together at the front of the pelvis. And when you look at it on an MRI scan, you usually see that there's some bone marrow edema, so signs of overuse in the bone. You'll see that the joint itself, the pubic symphysis, has some signs of wear, and it just doesn't look quite smooth in that area. You often have an adductor tendinopathy or even adductor tears sometimes, and abdominal tendinopathy together with that is not uncommon. So that whole area where the forces are being transferred across the pelvis can be affected with this. This is not an injury that develops suddenly. It usually takes several months to slowly come on, and it's that typical thing of, it's a bit uncomfortable, but I rested, it feels better, and I can run again. But then later on, it becomes so bad that you can't really run. Sometimes it's even that people have had groin pain for more than a year, and then suddenly it reaches a point where it just doesn't allow them to run anymore. In extreme cases, if you ignore it for too long, it could lead to full-on stress fractures. But most commonly, it just ends up being really angry case of osteitis pubis. Initially, the researchers that looked at the anatomy in that area thought there was a direct connection between your adductor muscles and your abdominal tendons. But now there's a bit of a debate whether they really attach to each other via fascia or not. Doesn't really matter, because if we think of it, the adductor muscles attach to the bottom of that pubic symphysis joint and the abdominal muscles to the top. So it's clear that they're going to work together as you move and as you require stability. And that's why as soon as one area is injured, it's going to place more strain on the next area in that place. And then it's going to lead to overuse on that eventually if you keep on training on it. So for this type of injury, you have to dramatically reduce impact, because you need to get the bone stress injury to settle down. You need that joint to settle down. And you need to start building stability and strength slowly, depending on the symptoms. So usually if you have osteitis pubis, it's going to involve cross-training as well as your strengthening exercises. With hip impingement, the pain is felt quite deep over the front groin area in this area, but it can refer out round to the outside of the hip and sometimes down the leg as well. And it's usually when you bring your leg up that it's quite restricted and feels like a pinching pain, or if you combine that especially with up as well as over and even higher up, but it can be quite restricted, this type of movement, that it causes a pinching in the groin when you have impingement. Now, with hip impingement, the actual cause might actually be what you did when you were a child. So let me explain. If we think of the hip joint, the hip is a ball and socket joint. So it means that there's a socket on your pelvic bone or pelvis, and your hip bone fits into that, and it can move smoothly into many directions. Now, sometimes the shape of either the socket changes, that it comes over and creates an extra point there, that when the hip tries to move in a certain direction, up usually or inwards, it impacts bone on bone too early, and that causes that pinch. Or it can be that there's a change in the shape of the neck of the femur, so that then causes it to impact early. And what the research has now identified is that it looks like these changes happen in the bones during the growing years. So when you're a child, your bones are quite soft, and because you're growing, and if you do a lot of high impact sports, so a lot of football or soccer with changing of direction, it's been shown that that can actually change the shape of children's bones to become the type of shape that can cause impingement issues later in life. Now, just because your bones are in that shape doesn't mean that you're necessarily going to have pain from it. It often just means that you're predisposed, if you do certain things or really forces hip flexion to happen, that it can cause that pain. Or if your stability isn't great, again, we're talking about lumbopelvic stability, because if you can think of your pelvis being allowed to go forwards more, that's going to change how your hip can move. Let me show you. So if you can imagine that my hip now doesn't have the full range to lift up before the bones make contact, if my pelvis stays stable, it gives me more range. But can you see, if I allow my pelvis to tilt forwards and now try to lift it, now I've got less hip flexion range. So I'm going to get impingement much earlier in my movement than if I had good pelvic stability and kept my pelvis backwards a bit to increase that range of motion. So that's why for hip impingement, it's not just about getting the muscles that control the hip itself nice and strong to support good movement. It's also about that core control and getting the lumbopelvic stability there. Not overcorrecting, because having a pelvis that's tilted too far back is also not good for you. It's just finding the best point for you that you can control to not get those symptoms. But often it's also linked to overuse, that you just didn't give enough recovery, you ramped up your training too quickly, and then because you became tired, your control that you normally have is pretty good, but then you lost that control because everything was pushed to the max, and that's why the hip impingement symptoms then flared up, because then the hip got impinged too much and caused inflammation. I'm lumping hip joint injuries together in this video because the symptoms are so similar and the treatment's so similar for it that you can't really distinguish between what's going on in your hip joint if you don't have a scan. And if we talk about the hip joint, it's between that ball and socket joint inside there, and it can affect the cartilage that line the socket, so the labrum, or it can affect the cartilage that lines the head of the femur, or the ligaments and other things that attach around it and form part of the joint. Most typically, it's for older runners, it's osteoarthritis of the hip, or a labral tear is also possible with running. If it's the hip joint that's painful, we talk about the C sign. So you often get people have their hand like that, and they'll come in and say, "Oh, I don't know what's going on, but my hip is really painful." And the pain runs from deep in the front of the hip, again round, and it can even be right to the back of the hip that you feel it, depending on which area is injured or how angry the hip is. So that C sign, if somebody does that, it's very likely that the hip joint is involved. Now, obviously, your physio will also look at movement tests, because each of these injuries that I've discussed have specific patterns in movement tests that fit with them. So for hip joint injuries, it's often also that bending up and crossing over and rotation movements that's limited quite dramatically if it's the hip joint that's injured. The thing with getting a diagnosis like osteoarthritis is that often people think, well, my hip is now knackered, it's wear and tear, and it's only going to get worse when I run. This is not necessarily the case. It may not even be the running that caused the wear of the joint. And it's quite common if you scan loads of people over the age of 50, most of them will have signs of osteoarthritis in their hips. And it's just a normal part of the aging process. As long as you can calm that hip joint down and you can give it good stability with core and hip strength, and be sensible with your running volumes and really just feel how it affects your hip, then it doesn't have to make things worse. So it's a very case dependent thing, and your physio can help you figure out what the best route is for you. With labral tears, I used to think as a younger physio a few years back that if you have a labral tear, you have to definitely repair it. And that's what patients also tend to think when they hear they've got a tear in their labrum, because if you've got a tear of something, you've got to repair it. But the research is actually showing that there was a recent study where they took 29 high quality studies and they looked at over 2,500 patients in those studies, and they scanned them, and they showed that in the people who didn't have any hip symptoms, more than 50% of them actually had labral tears. So just because you've got a labral tear doesn't mean you need to have surgery, because that tear is painful at the start when it happens, but then it can calm down and you can get full function back and it doesn't cause trouble further on. And what the research is showing for surgery, most of the time they don't actually go in and repair the labrum, they just trim the edges away that they think may be still causing your pain. And that's not actually great for the hip joint because it reduces the buffering of the hip joint. So the thinking at the moment and what the research is showing is that it's actually better to see if you can get it to all calm down and become a pain-free hip while the tear is there, because then you at least keep the cushioning in the hip. Bone stress injuries in the neck of the femur, as well as the shaft of the femur or your pubic bones, can all also cause groin pain. Now, the difference between a bone stress injury and a stress fracture is with a bone stress injury, there's no fracture yet. When you look on an MRI scan, it's showing there's some swelling in the bone and inflammation, and things are just not happy. And it's the sign that the bone has been overworked, hasn't got the building material to recover, and if you usually continue to ignore it, this progresses then on to the point where the bone then becomes weak and it actually fractures, at which point it's called a stress fracture. Now, the problem with these injuries is that the symptoms can be confusing. They feel very similar to other types of groin pain, and often they can be misdiagnosed. The key here is this is not the type of pain that improves with exercise. So if you start a run and it's uncomfortable, that pain usually doesn't go away during the run. It just gets progressively worse or stays there constantly. Also, it's quite common to feel pain when you're trying to sleep, especially with stress fractures, that it remains painful even when you're not doing anything. Common causes for this is either really high volumes of training and not enough recovery, so the bone can't recover between sessions. If you don't take in enough nutrition, the body starts shutting down certain functions. And one of those functions it shuts down to try and survive if you're not taking in enough calories while you have high volumes of training is your bone turnover. So it's breaking bone down while you exercise, but it's not actually rebuilding it during the recovery period because it just doesn't have the calories to do it. So nutrition is very important with this. Now, your physio or doctor will identify how likely it is that you might have this from what you tell them in how the history of how your injury started, how it reacts, and also through the physical tests they do. And if they suspect you have a bone stress injury or stress fracture, they will hopefully order an MRI scan, because these injuries, even the fractures, the stress fractures, do not show up on X-ray. They are often missed on X-ray because it's not like a traumatic fracture where there's a lot of bleeding and things that you can see easily on X-ray. You really need an MRI scan, otherwise you can miss them. The typical symptoms that you'll feel with this type of thing is the bone stress reaction usually develops slowly over time. So it gradually builds and builds and builds and become more painful over time. A stress fracture is usually easier to identify. Well, sometimes it's also that you can't remember a moment, but I've had runners report that while they were running a marathon, they suddenly felt something go in their leg and then the pain really started and intensified, but they've had that pain for a long time. Or even one runner was just doing a warm-up before her run, doing some adductor stretches, and she felt a click and it became really painful. She still ran 10 miles on it and then came to see us, and she was barely dragging that leg into the door. And when I suggested it might be a fracture, she was still like, oh, it's not painful enough. Now, to me, that sounded crazy because I could see that she was trying to force herself to walk on it and she couldn't really put weight on it. But that's often the mentality you have as a very long distance runner, that you can just ignore pain. And when they scanned her, it was a full on pubic stress fracture that actually happened. That adductor stretch was just strong enough to do the final job of causing the fracture then, because the bone had been painful and not well for such a long time. And this is one of the reasons why when groin pain doesn't react like it should react to treatment, it's always good to get a scan to rule out the more serious injuries. Step 2 is relative rest. Now, whenever you're injured, that area of the body loses some of its capacity to deal with the forces of running. So it means it loses a bit of its strength, endurance, and it becomes super easy to irritate and to make the symptoms worse. Now, what the research is showing that with the exception of stress fractures, most other injuries actually does better if you avoid resting completely, but remain active within limits of your discomfort or your symptoms. So with relative rest, you only cut out the things that really increases your symptoms, but you continue the things that doesn't really affect it. Now, depending on the structure you've injured, there's different levels of discomfort that's been shown to be useful or helpful while you train it. So to figure out what you can do, you do want to ideally understand what structure you injured, because that will explain to you or tell you how much discomfort is okay during exercise. If you have had your scans and there's no clear diagnosis, then you usually treat it in a similar way to tendinopathies, which I'll discuss in a minute. Then the second step is that you need to know and understand your baseline symptoms. How does your pain and your symptoms react day to day if you don't actually exercise or don't do your running? Because we're not interested in do you have symptoms or not. When you're injured, you will have symptoms. That's normal. We're interested in if you have your baseline level of pain, how does the activity you do affect that baseline? And then thirdly, you want to observe how it feels while you're doing the activity, as well as the delayed pain response, because many of these injuries have a delayed response 24 hours later that the next day often you feel, oh, that's a lot more uncomfortable. How much discomfort is okay to feel during exercise or afterwards? Well, if we're talking about a tendonitis or tendinopathy, it's usually okay if you feel a bit more discomfort while you're exercising. Quite often, actually, the tendon will warm up and you won't feel much while you're doing it. But then in the 24 hours afterwards, it's also okay to be a bit more aware of that tendon and the pain you normally have or the stiffness, but it shouldn't be a significant increase in discomfort. We have a lot more detailed content about each specific type of tendinopathy or tendonitis, which I'll link to in the description of this video if you want more detailed explanations there. But then if we think of joint injuries, absolutely same applies. Often with joints, actually, when you start the exercise, it can feel quite uncomfortable, but then it warms up and feels better for the 24 hours or so afterwards. If it feels significantly more uncomfortable, then again, it wasn't the right exercise for you there. Joints tend to like activities where there's not a lot of impact. So typically cycling or swimming or using the cross-training machine in the gym can be a brilliant way to get the hip joint happier if it's a little bit irritated at the moment. Then when we get to muscle strains, there you don't really want to feel much when you exercise. So if you're feeling anything that you would class as discomfort or pain while you're exercising and you have a muscle tear or a muscle strain, then that activity is not right for you at the moment. It's okay to feel that the muscle is working or that you moving that area, so you're aware of something there, but it shouldn't be discomfort, it shouldn't be pain. If it's either of those, then the activity you're doing at the moment is not the right thing for that muscle tear. Same thing goes for stress fractures. And here I also want to say that because with bone stress reactions and stress fractures, It's often that overuse without taking in enough nutrition that's part of the cause. And I have seen that people with stress fractures actually have delayed recovery because they've now switched to low impact, like cycling, but they've continued with really high volumes and not really allowed the body to recover. And the amount they've eaten, even though they've upped it, has not been enough. And then the bone can't recover that well. So it's quite often better with stress fractures or bone stress reactions to reduce the intensity of the exercise and the volume dramatically for 4 to 6 weeks or even 8 weeks, even if it's low impact, just to allow the body time to recover and reset. Now, your physio can help you figure out all of this. This is part of the reason why we take so much time in that initial assessment to really understand your symptoms and how they react just to normal things you do in life. And we teach all our online patients how to use the pain system for their specific injury and what levels of discomfort is okay for that injury. Because the idea is always to get them to be able to function independently, because we don't want to be looking over people's shoulders the whole time. You need to be able to apply that to all things you want to do in life, because you might want to suddenly do an activity that you weren't even thinking about over the weekend with your family, and then you know how to gauge it. So it's really important to discuss all of this with your physio, that you can understand how to apply it to general life as well. All groin injuries usually benefits from making sure that all the muscles around the hip as well as the pelvis is nice and strong and in balance. Good lumbopelvic stability and core strength and control, those two kind of goes together. Working on good leg control during movements like the single leg squat, we've got videos about that. And also good balance. Then also it's useful to have adequate flexibility around the hips and groin area. Now, I say adequate because you really don't have to be super flexible. Because things can feel so tight when you get injured, they often blame being overly tight on the injuries you have. Now, sometimes tightness can influence it, but it's often not the main driving factor. It's often when other things are weak that other stuff becomes tight. And if you stretch certain injuries like tendinopathies or tendonitis too aggressively early on, it actually just makes the pain worse because it irritates the already irritated tendons just more. So with stretching, it's often better to not have long, sustained stretches when you introduce them, but rather more active, gentle stretches where you just move in and out of the positions gently. But your physio will help you understand when the best times are to start introducing these exercises and how to build them over time. Because the important thing here is that, yes, these principles of strengthening is exactly the same things that you need to be strengthening for all these different injuries. But how you go about it is going to be very different depending on your specific case, because every person will have a different level of strength when they start. The area that's injured will have a different tolerance to force and activity, and their pain levels will vary. Some people can have quite a significant injury when you look at a scan, but not much pain, and it doesn't flare up easily, while others might not really show much on the scan, but their pain gets triggered really easily. So the exercises you start with and how you progress has to match your injured area's capacity at the moment. So how strong it is, plus how sensitive it is. And that pain response that we spoke about in the relative rest section needs to be kept in mind the whole time, because if you push into too much pain or discomfort, it just triggers the pain system and then that becomes sensitive and your pain just increases. So it's important to understand that just because I say strengthen the glutes doesn't mean that glute bridges is the right exercise to start with immediately. It has to be tailored to what you want to do. And then it's got to build up to the level that you need for whatever level of running or sport you want to be doing. We're often consulted by runners who did all their rehab, did really well, went back to running. It was okay for a couple of weeks, and then the pain came back. And when we listen to their rehab plan and what they've been doing, it's clear that they did some strength training and some control training, but they didn't actually do it heavy enough to match the loads that they need for the type of running they want to be doing. But it's also not always just about picking up heavy weights. Sometimes it's just about how long they've been doing that for. Because to get proper strength gains, you have to be doing consistent strength training for at least 12 weeks. Now, this period of time might be less or more depending on your starting strength and irritability, if you've had a chronic grumbly tendon or osteitis pubis for quite a few months or even a year before you start with it, then your strength training plan needs to last for at least 6 months. Sometimes it takes 9 months or longer to get back to full running. The 3 boxes you've got to tick in your rehab plan before you go back to running is that you should have done heavy strength training for a number of weeks that's enough to actually give you proper strength gains. You should have good control as well as the strength. And you should have that minimum level of flexibility into movement directions that we spoke about. Step 5 goes hand in hand with step 4, really, because even if your plan builds up to the correct level that you need for your running, if you don't do a gradual increase in running or return to running, and you ramp up your volume or your intensity or too heavy terrain too quickly, then you can overwhelm that area that it doesn't have enough time to strengthen to that level of running, and then the injury can recur. So the best way to avoid this is by introducing run walks. We tend to think that, especially if you're used to running 50 miles, 40 miles a week, doing a 5K run continuously might sound like nothing to you. But if you've been off from running for quite a long time, that area may not actually have the endurance to cope with 5 kilometers of continuous running at this point. And when you do a run walk, it has 2 benefits. One is that if your injury does decide to flare up, it's usually just mildly more uncomfortable, settles down quite quickly, and you can get on with things. Whereas if you do a continuous run and it flares up later on, it's usually really pissed off with life. Then it takes several days, sometimes weeks, to calm down, and it can feel as if you're back to square one. So run walk can be useful in that way, but also the walk intervals just allows that tissue that little bit of recovery time that it can go again. So I find in my experience that people can often run more in a session when they do run walks than if they try to do continuous running. How quickly people can progress from run walks and how conservative they have to be with the run sections versus the walking sections really depends on how long they've had the injury for, how sensitive that injury is, what type of injury it is. So if you've had a bone stress reaction, being very conservative with your run walks is usually better. If you have a tendon injury, if it's not been there for that long, it can be that you can actually ramp things up more quickly. If you want a very conservative run walk plan for injury that's easy to irritate, then I've put a link in the description of this video that you'll find that there. Something that can help smooth your return to running is if you make sure that you actually build your walking intensity and volume up significantly before you try a run walk, so that then when you add in the run bits, you already know your legs have the endurance and the ability to cope with walking on that terrain, and you just add in the running as a progression there. Brilliant. Hope you found that useful. Let me know in the comments if you've got any questions. And if you need more help with your injury, you're welcome to consult one of our team via video call. The link to the website is also in the description of this video. Take care.